A very good evening, everyone. Welcome to yet another session in the series of Nightingale, a program for the nurses by the nurses. Today's session is named Sachet, is on managing emergencies, collapse, OHSs, and anaphylaxis. We have with us Dr. H.S. Saini, sir. He's a heading Department of Anesthesia at Bansal Hospital, Bhopal, and is the lead anesthetist for liver transplant. In addition, he's a registrar in DNB academics. He is well-known faculty for medical education, regional anesthesia, quality and process optimization, in OT and critical care. He has many publications in reputed journals. His prior appointments were at CKBH Jaipur, Max Hospital Noida, and Nayati Healthcare Mathura. We welcome you, sir, and
thank you.
Shall start the session, sir.
Yeah. Is the screen share done?
Sir, please share your screen.
Yeah. Are you able to see?
Yes, sir.
Okay.
Make it
So
full
good
screen,
evening.
sir.
Yeah, it is taking some time. Done?
Yes, sir.
Done, sir.
Okay. So good evening, everyone. Thank you for giving this opportunity today. So I'll be talking about the emergencies that we see commonly in an IVF footing. So I have no significant disclosures, and I have tried to update myself with the guidelines of the standard organizations concerning the anesthesia and the reproductive medicine and the accreditation bodies. Now, commonly, there are three surgeries that we do in a IVF boutique. The most common is a ovum pickup and maybe sometimes an embryo transfer, which will require anesthesia, and a TISA. So these procedures can be done almost in any kind of anesthetic technique. It could be a standard general anesthesia technique. It could be inhalational based or an intravenous agent based. They could be done with a airway device or without any airway device, like just with a flexi mask and oxygen supplementation, or you could be holding a mask and doing this. Now, the most common technique that we use for these patients is called total intravenous anesthesia. Now, in most of the places, these procedures are quickly done by our Christian counterparts, and they just require hardly 5-10 minutes of a immobile patient. So, and most commonly, what we use are the drugs as shown in the slide. Now, what are the things which can go wrong? Now, most likely that you will see most often in these patients is a respiratory depression, which will be manifested as either a fall in the oxygen saturation or the patient not breathing at all. The second most commonest thing that you see is a fall in the blood pressure. And if you have a bad luck, you might be seeing some allergic reactions, simple or maybe anaphylaxis. There may be arrhythmias, there can be cardiac arrest. Rarely you may see hemorrhage, and if your patient has not taken proper fasting, then they might end up with vomiting. So these are the common complications which you see in a IVF 40. Now, it's always better to prevent complications than managing them. So our entire stress should be on preventing complications in the IVF 40. Now, for prevention of all these things, we need a combination of a good infrastructure, a ready availability of all the drugs and consumables, and a team which understands what needs to be done and what needs to be avoided, and a very strict adherence to SOP. Time to time, we have drills and a debriefing of the team as to what was being done in the right way or what was not to be done. So I'll try to deal with this topic in some of the parts that I have shown in the slide. And the very important thing is you need a well-designed OT structure. That is the responsibility of the management. You need a fully functional anesthesia workstation. You need a continuous supply of oxygen, which could be pipeline-based or cylinder-based. And even if it is a pipeline-based supply, you need to have a backup oxygen cylinder in the theater. You need a good working suction, preferably two, Maybe one could be a pipeline and one could be a mobile unit. Now, because these OTs are not properly illuminated, there are chances of having a drug error because of poor illumination. So there should be at least a provision for having an additional light towards the anesthetic end. And there should be a lot of working space so that you can move around. Sometimes these IVF OTs are made in a very small place. And of course, you should have a ready access to the drug and the crash cart in your theater. Now, the most common emergency drugs which you should always keep in the backup are atropine, adrenaline, hydrocortisone, Avil, darifalin, suxamethonium, ephedrine, lignocaine plain, 2%, 30 ml vial, and some antiarrhythmic agents like metoprolol, esmolol, and deltiazem. Now, the most common anesthetic agents that we use in the IVF OT are midazolam, fentanyl, propofol, ketamine, dexmedetomidine, of late remifentanil, and some of us use inhalational anesthetics. It could be a combination of any of these drugs. Now, coming to the consumables which should be readily available in a theater are gloves, the various sizes of intravenous cannulas, sterile swabs, IV sets, three-way stopcock, syringes, ECG electrodes, IV fluids of various contents, antibiotic, and suction catheter. Now, you need an anesthetist and an anesthesia technician to assess the anesthetist every time a procedure is being done in an IVF OT. Now, we follow the standard procedures in the IVF OT. That is, whenever you take up any case, make sure you do a proper pre-anesthetic checkup and you counsel them of what needs to be done and how they are to be getting themselves ready for coming to the theater. These patients, they need to be investigated. Of late, the age for which we are doing IVF procedure is going on the higher side. So there are multiple cardiovascular and respiratory or other comorbidities, especially obesity. So you need these patients to be thoroughly investigated. And in case there is any comorbidity, they need to be optimally optimized. This patient should be having a standard instruction of 6 hours of fasting, and you need to follow the minimum standard of monitoring. I will be going into all these one by one. So first is the pre-anesthetic evaluation. So these patients, they need to be told about fasting, that is at least 6 hours. The bare minimum that you need to know about these patients is whether they have any allergy so that you can avoid them. And the most common drug is diclofenac, which is used for pain relief, should be well documented. Some of the comorbidities which may be there are like diabetes, hypertension, or bronchial asthma. They should be ruled out and they should be adequately optimized. Similarly, hypothyroidism. Then if there's any history of airway related issues in the past, that should be known so that you can avoid it. Like any patient having unanticipated difficult airway in the past, you have to be very careful while dealing with these patients, even if it is a sedation for a short duration. Sometimes this patient will conceal a history of having convulsions in the past due to so many reasons. So one should be very, very tactful in eliciting the history of seizure. And then, of course, the congenital cardiac issues should be unearthed while dealing with these patients. Very importantly, you should know about the effort tolerance of these patients. Then, when you are assessing these patients, make sure that you assess the patient for airway management, venous accessibility, and make sure that you put an stethoscope and hear for their heart sound so that you know that these patients do not have any valvular heart disease. The bare minimum investigation that you would do in these patients are serology, the CBC, and ECG and echo if the age is on the higher side, or if they are having obesity and poor effort tolerance. So whatever known unknown comorbidities are there in these patients, they need to be optimized. They should be given a standard instructions to be fasting for solids for 6 hours and for liquids for at least 2 hours. So whenever you take these patients to theater, the minimum standard of monitoring by the ASA or ISA should be applied. That is a continuous running ECG, oxygen saturation, an intermittent non-invasive blood pressure, and a measurement of end-tidal carbon dioxide. And very importantly, the clinical monitoring by the anesthetist. So what are the equipments which should be available to handle the emergencies? So very first thing is workstation. Dr. Deepika, am I visible? Hello?
You are visible, sir, but the screen has stopped. The screen sharing,
Okay.
which was
Okay, let me do it again.
yeah. Yeah.
I think there was a power fluctuation and yeah. Is it visible now?
Yes, sir, it's visible.
Yeah, okay. And of course, you should have endotracheal tubes, suction catheters, monitors, and ECG electrodes. Now, the conduct of procedure is that always you should sedate the patients and then go for positioning and painting and draping of the patient. The most common technique that we use is a combination of various anesthetics like midazolam, fentanyl, propofol, ketamine, dexmedetomidine, which is called TIVA. Now, precaution should be taken that every patient should be adequately anesthetized before starting the procedure. So there should be a clear instruction from the anesthetist that once the depth is achieved, they should request the obstetrician to start with the procedure. Always make sure that there is a two-way communication so that if there is any problem at either end, the other person knows. And lastly, at the conduct of the procedure, the patient should be shifted to a recovery or a PACU. Once the patient is in the post-op care unit, the patient should be kept in a recovery position. They should be monitored and you should give appropriate thermal comfort to these patients. There can be some element of respiratory depression, so I should do oxygen supplementation and make sure that you take care of their post-operative nausea vomiting and always have one person supervising the recovery in these patients. Now, after the procedure is over, you need to have a complete documentation of the PAC, the review PAC, the anesthesia monitoring, and the condition at the time of shifting out of the theater. Now, I will skip this slide. Now, at regular intervals, the management should be conducting periodic drills for simulating the various emergencies so that everybody is geared up to deal with them when they occur. And at the end of the session, there should be a team debriefing so that everybody is aware of what was done in the right way and what was not done in the correct fashion. Now, there are some special circumstances which I will be dealing one by one. So very first thing is that when you give the anesthetic, some of these patients will stop breathing. So that is known as apnea. So the very first thing that you do whenever there is a apnea is that understand that it is not a complication. It is a part of the anesthetic technique. So at the peak of surgical anesthesia, the patient will go into apnea. So you need to assess the ventilation. So you should not panic. So use your circuits on the anesthesia workstation and do a bag mask ventilation with a closed circuit or with the Bain circuit or the C circuit, whichever is available. And you should withhold further administration of any more sedative or anesthetic drugs. Now, very commonly, these patients will go into apnea not because of the respiratory depression due to anesthetic, but it is because of the airway obstruction. So at that time, what you should do is a simple airway maneuver or put a oral or a nasal airway and do what is called triple maneuver. I'll show a video for that. So this is a video. What you can see, let me play it for you. So all that you need to do is just lift the chin and do extension of the cervical spine. Can you see the video clearly?
Yes, sir.
Okay. So the first part is just lift the chin up
Some make it full
and the
screen.
next part is do a jaw thrust.
Sir, can you share your screen like a full screen thing?
Okay.
Yeah. Thank you, sir.
Okay. So the patient will start breathing if there is airway obstruction. and you will be able to see the mist on the flexi mask like this. So some of the patients, just a simple chin lift would not suffice. So all that you need to do is put your fingers behind the angle of the mandible and lift it up. Now, the second most important thing that we would be seeing in the theater is a low oxygen saturation. So if it is associated with apnea, all that you need to do is a bag mask ventilation and ventilate the patient with 100% oxygen. But if there is no apnea, all that you need to do is make sure that the partially obstructed airway is taken care of by putting in an oral or a nasal airway, and make sure that the patient is receiving 100% oxygen. Now, the second annoying thing that you might see is a fall in the heart rate. So that is known as bradycardia. Sometimes it can progress to cardiac arrest. So if there is a fall in the heart rate, you should be giving 1 ampule of atropine, that is 0.6 milligram. So most of the patients in IVF are adult patients weighing approximately 40 to 60 kilos. And so 0.6 milligram is the standard dose which you give. In case there's only a slight fall in the heart rate, you can resort to using glycopyrrolate, that is 1 ml, 0.2 milligram. And sometimes if it is associated with a fall in the blood pressure, you might add either ephedrine, that is 3 to 6 milligrams, or methylphenidate. Now, another thing which you will very commonly see in the IVF OTs is, because these patients are fasting, sometimes there will be prolonged fasting, and you might end up, giving anesthesia rapidly because you have a lot of procedures and there's not much time to give appropriate hydrations to these patients pre-operatively. So the very first thing is you give fluids to these patients. So give a bolus of something like 100 or 200 ml and repeat it if required. The second thing is you give them head low position. So this may not be possible because it may not be comfortable for the person on the other end to continue with the procedure. So the next thing that you can do is give a bolus of either 6 milligrams of methylphenidate or 3 to 6 milligram of ephedrine. Very rarely you will have to resort to using an inotrope in these patients like norepinephrine infusion. Sometimes you will come across with allergic reactions in the OT. So these are usually subtle. They don't need much to do, but all that you need to do is wait and watch. Make sure that you're observing the patient and you are on guard so that in case it is progressing to severe type of allergic reaction, you are ready to deal with it. So most of the time, it will suffice by just giving some Avel or hydrocortisone. Now remember that histamine release will act on both H1 and H2 receptors. So just giving Avel is not enough. You have to add ranitidine to these patients as well. The most dangerous thing that can happen is anaphylaxis, which is a severe form of allergy. So the very first thing is the moment you feel that the patient has got anaphylaxis, you inform everybody in the theater and call for help. It's always when you have more number of hands, things are better managed and they're easy to manage. Now, the first drug that you should be giving whenever there is anaphylaxis is adrenaline. So you take 1 ampule of adrenaline, you dilate it to 10 ml and keep on giving 1 or 2 ml, 1 ml boluses every few seconds till you get a desired effect. Now, the desired effect is titrated by either the heart rate picking up or the patient's blood pressure picking up. Then you have to follow up with the other drugs like giving hydrocortisone 100 milligram IV, giving Avel, giving ranitidine to this patient. Now, in case there is uh, this one bronchospasm at this stage because of anaphylaxis, you can either resort to giving an injectable darifilin or a minofilin, or you can nebulize these patients with an inline circuit. Now, sometimes nebulization is not possible because the patient is breathing spontaneously, you're on TIVA and just a flexi mask. So that's where you always resort to an injectable agent. Now you have to be very careful, though it's easy said and difficult to do, but still one should make an attempt to remove the offending agent. And thereafter, you should think of putting in fluids and inotropes if the blood pressure doesn't pick up. And very rarely, if the patient is having respiratory distress, difficulty in breathing, or there is stridor, you will think of intubating the patient and then sending the patient to a post-operative care unit. Sometimes those patients can have seizures, and This can happen either because of the history being concealed or the patient having not taken the routine dose of an anticonvulsant. So all that you need to do is immediately push in some midazolam, fentanyl, or just midazolam or diazepam, which is easily available in controlling the seizure, and make sure that the patient's airway is maintained and they are breathing. And in case there is apnea at this stage, you do a gentle bag mask ventilation. So, very rarely you might come across these patients throwing up. So all that you need to do is immediately give a head low position or a recovery position and do a suction and give drugs like metoclopramide or pantoprazole and ondansetron. Sometimes there can be an equipment failure in the OT. So whenever there is an equipment failure, you have to be having a backup. So you should always be ready to deal with almost any kind of equipment failure. So in the anesthetic side, there can be a failure of the anesthesia machine. It may just stop working. So all that you need to do is give oxygen supplementation directly from the cylinder, or if the patient is in apnea, or let's say you are doing a controlled ventilation, do a bag mask ventilation on room air and do a replacement of the anesthesia machine. The next is there can be a monitor malfunction at any time. So for this, all that you need to do is do not panic. Keep a hand on the pulse and you keep another finger close to the nose. You will be able to see that the patient is breathing. And of course, you keep your eyes on the chest and look for the respiratory excursions. That will tell you about whether the patient is breathing or not. And lastly, there can be a power supply failure at any time. So if that happens, make sure that you have an emergency torch at hand. If that is also not available, use your laryngoscope to light up the theater and make alternative arrangements. Sometimes there can be a fire in the theater. So for this kind of emergency, we follow what is called the code red. So always follow your hospital protocol. So very first thing is you need to cut off the fire. So for that, either you remove the oxygen from there or remove whatever is the offending agent. In case it is electrical fire, you don't put in any water on that. You try to put off the power supply first. And then you think of evacuating the patient from the source of fire. So that is the scene safety for yourself and the patient. And thereafter, you do the fire management. So you flood the area with water if it is not electrical fire. So what are the checklists which you should have when you are dealing with any patient in the theater? So I'll put it in two ways, that there is a responsibility of management to follow a checklist and there is a responsibility of the staff. So what the responsibility of management is, that they have to provide an appropriate infrastructure for building the theater and putting in the necessary equipment and drugs available there, making the necessary consumables available in the theater, and putting in the appropriate standard operating procedures for each and everything, as I have shared earlier. Time to time, everybody should get together for doing the practice of managing the different emergencies that may happen in these workplaces, and then do audits. And whatever the audits will tell, you should take those inputs into account and modify your processes appropriately. Now, what is the responsibility of the staff? The very first thing is everybody should follow a standard operating procedure, whether it is a doctor, whether it is a nurse, or whether it is the anesthetist or the anesthesia technician. Next, whatever equipment is there in the theater, you should be checking these equipment at a periodic interval. That is, you should check this equipment every day. Every time you start a case, you should check this equipment. Every time you take in a new patient, you should be checking all the equipment, whether they are working or not. Then there are a lot of drugs available in the theater, so we should check the expiry date of these patients, because when there is an emergency, you're always in a hurry to push in the drug, and that's not the time wherein you will have sufficient time to check the expiry date. Very important it is that you should avoid drug errors. Medication errors are very common errors which occur at the end of the anesthetist, especially because of being in a hurry or being working in an area which is poorly illuminated, because you are using an ultrasound in this area. So drug errors can happen. So you should make sure that you load your drugs one by one, label them, and follow the standard dilution practices of the department. Lastly, it's good that if you can manage whenever things go wrong, but try to have a more focus on preventing the occurrence of any of these complications. And whenever things go wrong, you should always report, fill in the critical incidents form and do a CAPA so that you know what went wrong and how you can prevent it in the future. And very important, whenever things go wrong, the healthcare worker should always call for help. Multiple hands and brains are always better when you're dealing with a difficult scenarios in the theater. With this, I conclude my presentation. If there are any questions, I'll be happy to take them.
If anybody has any question, please, you can put it in the notes box and we can take those questions up.
Dr. Deepika?
Yes, sir.
Yeah. So I made an attempt to illustrate what we do, what are the things that go wrong, and how we can be ready to prevent them. And once they occur, how do we manage them?
Thank you, sir. You've presented it very nicely. Every day-to-day problems and what all can go wrong. Things which we don't actually think of when we take the patient in the OT. And when it actually happens, then it's a problem. So,
Yeah.
and thank you very much for taking out a time on a Sunday. It's very difficult to be available on a Sunday. Thank you very much, sir.
Yeah. Thank you.
Do we have, we wait for 5 more minutes, sir, and then we conclude
Yeah,
if
sure.
there are any
Yeah.
questions.
Okay.
There are no questions, sir, as of now.
Okay. So can we sign off then?
Yeah, I think so. Thank you so much, sir, for explaining this very beautifully. And it will help the staff for being there, promptly acting on any such situations if it happens.
Yeah. Thank you.
Thank you, sir.